This is Selma Schimmel for the Group Room in Chicago at the AACR annual meeting, the American Association of Cancer Research. Joined now by Dr. Roy Herbst, Professor of Medicine, Chief of Medical Oncology, Associate Director for Translational Research, Yale Comprehensive Cancer Center, and Yale School of Medicine in New Haven, Connecticut.
Thank you.
Hi, Doctor.
Hi, thanks for having me.
It's great to see you back, Dr. Herbst. Thank you for spending time because we're going to talk about smoking cessation and recommendations that have been published in the Tobacco and Cancer Task Force. What is the Tobacco and Cancer Task Force?
Well, about 2 years ago, Marge Foti, the executive director of the AACR, commissioned a group of us to get together to look at the AACR tobacco statement, talking about the risks of tobacco and the ways to combat it. And actually, it hadn't been revised in about 20 to 25 years. And it was perhaps a paragraph that was part of the AACR documents. So with so much now known about the risks of tobacco and its cause of cancer and ways that we can try to combat that problem, we thought it would be very good to bring a group together to revise the tobacco statement for AACR. And what happened was I was chairing that group. We brought together about 15 of us from many different disciplines, medical oncology, from prevention research, from pharmacologic interventions into tobacco cessation, communications. And we met over the course of 6 months. And in April of 2010, we actually published in Cancer Research the AACR tobacco statement. And we realized that that was such a good exercise that we kept the group going as a task force.
I'm curious what has changed in the 25 years and what are the language changes that were implemented?
Well, certainly the timing could not have been more perfect because right now with the Family Tobacco Act, almost that old as well, a couple of years old, there's a great more ability for the FDA to regulate tobacco products, but they're looking, of course, for direction. They're looking for evidence that they can use to produce different guidelines. Well, the first thing that we looked at was just the smoking rates, in the U.S. Population, which, in the 60s and 70s were as high as 50%, of Americans. And it's come down gradually to the point where about 20% of Americans still smoke. That's the good news. The bad news is 20% still smoke, and it's not going down any further. And in fact, there are a great deal of disparities involved in this as well. If you look at low-income, minority populations, their smoking rates are much higher.
Young women.
Young women, and of course, with all the marketing that's been done by tobacco advertisers in the past. So it's certainly something that we recognize in this task force. Nicotine and its addictive features. We have guidelines for how do we regulate nicotine in cigarettes, and it's not actually just cigarettes we're looking at in this document. We're looking at all different forms of tobacco, either smoked or applied into the mouth and other areas.
We understand that there is a resurgence of interest in chewing tobacco and great concern amongst our youth. And when I mentioned women, the incidence of younger women taking up smoking.
Yeah, younger women and children, and young adults that are smoking, the numbers don't look good, and we really need to do something there as well.
What was the Family Tobacco Act?
Smoking is related to at least 18 different types of cancer. And what the Family Tobacco Act was a bill that actually gave the FDA authority to regulate tobacco products. Incredibly, they were not regulated until then. And that's important because this will allow them to regulate all forms of advertising, all forms of formulation. For example, how much nicotine can be in a cigarette. They're not allowed to bring that level down to 0, but they are allowed to regulate it, as low as they possibly can. And an example would be what's just recently come to press, tobacco warning labels. So one thing that's, one of the first projects was to revise the tobacco warning labels. That's been somewhat controversial.
With the images.
With the images, but to go, to very graphic images. Some might even contest that those might not be as useful as a more gain-framed positive image, but that's something, that's being worked on right now. Certainly our committee is trying to advise regarding menthol, in cigarettes.
Does that even raise the danger, the menthol addition?
Well, it talks about commissioning a study to look at it, and that is something the FDA has been looking at as part of this Family Tobacco Act. But it gives them a great deal of resource to do research into methods of tobacco cessation, into the risks of tobacco use, and of course to regulate in a way that can create advertisements and other communications methods to try to decrease tobacco use.
I have also noticed some of the new television commercials that very hard to watch, really disturbing.
Right, and again, one of the things that the AACR and other groups should help foster is research into how effective are those methods. So you might think on the surface that might be, it's very graphic, perhaps that's very useful to especially young people who might smoke. I myself, every November during Lung Cancer Awareness Month, go to different schools and I use very similar images to talk to students. My hope is that that would be effective. There is some research actually from some of my colleagues at Yale that would suggest that those negative messages can only help so much, and perhaps a more positive gain frame message, if you don't smoke, you'll feel better. Showing someone feeling better or doing active things might be just as useful, if not more.
Well, yes, there's this new one, watching a gentleman dying, and
right. So some of them are quite graphic.
Very.
But it is incredible to me, as a physician who cares for lung cancer, and my practice has been pretty much exclusively lung cancer for almost 18 years now, that more than half the patients that I will see will already have metastatic disease. So and that's incurable. So the idea that we could prevent 80+% of lung cancers with smoking cessation, is very compelling, and is one of the reasons why I've put so much interest and effort into this campaign. Well, what our session was on here was we were actually looking at smoking in cancer patients. So one thing that is incredible, that even once diagnosed with cancer, many patients will continue to smoke, and that again, some might say, well, why bother but many of these patients have curable malignancies, and even those whose cancer might not be curable but it's treatable, we now know that they'll do worse if they continue to smoke on therapy. And actually Graham Warren and Ben Toll and other physicians on our panel here actually show data that patients do worse when they in fact are smoking. Part of that might be the metabolism of drugs, part of it could be the comorbidities associated with smoking. But clearly there needs to be a push now to help patients who have cancer to stop smoking. Plus that they're at risk for second malignancies and other primary tumors.
In closing, what about some of the cessation methods that you feel are the easiest for patients, or smokers rather, to adapt to? This
is a problem, because many of these are not readily available to all populations. Some medical centers offer free treatment to their patients with cancer. For those at high risk, smoking cessation clinics with either psychologic methods or pharmacological interventions, drugs such as Chantix and others, can be quite helpful. But really, it has to be. It's my feeling that there needs to be more education. This has to really be brought to the level of the primary care physician and the internist, and really there need to be defined programs. Most every state has a quit line where you can call a 1-800 number, and if you call that number, one can be brought to the proper groups who can help with these different interventions.
A lot of patients are afraid of the Chantix because of the psychological side effects, the potential or suicidal thoughts. How significant is that as a risk for patients?
Well, certainly that's the problem, all these pharmacologic interventions are drugs that could have potential neuropsychiatric side effects. So it is a concern, and that's why I think they need to be done with close supervision, with people familiar with how they work and their administration. But I think in some cases it might be the only way, drugs of that ilk, to try to help patients. But
and the patch is still available?
Patches are still available, the gums, and methods of replacing the nicotine, certainly are all things that can be tried. And the way we do it at our hospital at Yale is we have a smoking cessation service. And I'm actually quite proud of that, because not only do we work with the general population, which is in a city of like New Haven, an urban population, maybe 30 to 40% of people are smoking, but in patients that we're bringing in for screening, for example, for lung cancer. So now we're screening for lung cancer in patients who are 30+ pack year smokers. Either they've smoked in the past or they're currently smoking. For those who are currently smoking, they can get their screening for their lung cancer, but at the same time, they go and meet the smoking cessation group who work with them to try to help them to stop smoking.
And does that include sort of support groups also for smokers to gather?
Right. There is a support group, and that meets on a weekly basis. And again, everyone benefits from different things, and this is a field that needs continued research and resources, both primary and secondary resources.
Thank you very, very much, Dr. Roy Herbst, Professor of Medicine, Chief of Medical Oncology, Associate Director for Translational Research, Yale Comprehensive Cancer Center, and Yale School of Medicine in New Haven, Connecticut.
Thank you very much.
Thanks for your good work.
Yeah, thank you. Thanks.